Today we have the great pleasure having Rajiv Jalan with us. Rajiv is well known all over the world for his pivotal work on acute and chronic liver failure, which is something very new on the hepatology scene, but very important. He is a group leader of the liver failure group at University College London, the Royal Free Hospital, where Fegato started the whole thing. And Rajiv will address the issue acute and chronic liver failure, a new syndrome that has reclassified cirrhosis. Please, Rajiv.
Can you see my slide?
Yes. You maximize your screen and we are done. That's it.
Okay.
Perfect.
Can you see my
Yes.
mouse?
Perfect and clear.
All right, lovely. Okay, well, thank you very much for this very kind invitation. And I'm really sorry that we've had to wait around for a bit. So look, acute and chronic liver failure, as you know, is a syndrome that is not so old. You know, it was only defined through the large canonic study only about a few in 2013, 2014. And I can say that, you know, following the description about 20 years ago, it now has over 5,000 papers in the literature. So it's very new, very exciting. And the problem that we have is it's a syndrome which affects many, many thousands of patients, and we have no treatments for it. So here are my disclosures, and most of these disclosures really relate to how this new syndrome is being treated, new treatments that we are developing for it. And so therefore, none of these are really relevant to my talk today. This is what I'm going to talk a little bit about today. So what is ACLF? And where does it fit into the trajectory of liver disease? To keep with this whole idea, how it has reclassified this whole cirrhosis journey. How does it develop? So what is the main pathophysiologic basis of the syndrome? And I'm going to tell you finally about why I think it is so important for us to know about it and how this field is evolving in its treatment as we move forward. So just to put the story into context, you know, we think about cirrhosis as a very serious condition, except that, you know, for a large part, patients who've got compensated cirrhosis can remain compensated for a really long time. So here is a story of David, who is a 52-year-old man who drinks excessively, but he is very well. He works full-time as an accountant. He came to see us. We did a routine health check, including a FibroScan and liver biopsy. We diagnosed him with compensated cirrhosis. And essentially, he was well for the next 4.5 years, continued to drink little amounts of alcohol, not very much, and was admitted to the hospital with jaundice after a 6-week binge. And at that time, he had marked inflammatory responses. You can see here, he had ascites. He had bilirubin of 5 milligrams per DL. So he had deteriorated acutely. But what happened to him was that he progressed very rapidly within a course of these next 5 days or so to develop multi-organ failure. And he died from this multi-organ failure 5 days later. And it's this sort of syndrome that we are trying to capture within different, how we define the trajectory of David, who was completely well before admission to the hospital, and then had a very rapid progression and death. So it is trying to understand where is this demarcation between acute decompensation, ACLF, and what happens to these people in the future. So, and this really talks to my title about how ACLF is changing the reclassification. So here is David at the outset. He's got cirrhosis, but he's very well. He's got no clinical signs. And he comes into the hospital with ascites and jaundice. And he is in this category here when he comes in. What he has is what we call pre-ACLF, but of course, a large proportion of these patients have got no ACLF. He's in a high-risk category, which progresses rapidly to a syndrome, which I'm going to talk about more, called ACLF, which is characterized by multi-organ dysfunction and a high risk of death. And unfortunately, he's in this corridor here, where he comes in this orange block here, no ACLF, but predisposed to development of organ failure and dies very rapidly from multi-organ dysfunction. So within this, if you can see, there are many clinical phenotypes. So there are these patients here with no ACLF, low risk, but here is a group very high risk of progression to multi-organ failure and death. But for the most part today, I'll be focusing on this group here, which is high risk of death and patients that have got acute on chronic liver failure. I'm not going to talk much about what happens to them in the future, which is another talk entirely in its own right. So if you think about David, this is his clinical description. So he has underlying alcoholic cirrhosis. He goes on a binge for 6 weeks. So he's got superimposed alcoholic hepatitis. He presents to us with an inflammatory injury. So he's got severe systemic inflammation and then progresses rapidly to development of this brain dysfunction, progressive liver failure, coagulopathy. And I'll come back to describe to you the new score that we developed for prognosing on this. So within thinking about this and simply from the descriptive perspective, we think about it as what we call a pyro concept. What is the predisposition? What's the injury? What is his response? What are the organ failures? And defining the risk of death. So within this program, this is how we can think about him. So these are 3 patients that I'm not going to describe to you today. So here is, for instance, what the most important causes in Europe in terms of their alcoholic cirrhotic presenting for the first time with a complication of cirrhosis. The most common is really bacterial infection. And as you can see here, this is overrepresented in those with more advanced ACLF, which I'll describe to you in a second. Active alcoholism is also very prevalent and was recently proven in the PREDICT study, where the 2 most common causes of acute decompensation that brings cirrhotic patients to the hospital is bacterial infection and active alcoholism. Gastrointestinal bleeding is less represented, and that really relates to the idea that our management of these patients is now a lot better. So they're not presenting with that much of ACLF type illness. So if you keep this at the back of the mind, a cirrhotic patient has an acute decompensation, is coming into the hospital. And what we tried to do and this is obviously the most important study in the literature, it is by Richard Moreau in the canonic study, which really what we did was to take nearly 1,400 patients and we followed them agnostically when they were admitted to the hospital with this episode of acute decompensation. An essential question was as to what are the determinants of high risk of death for this population. And what we came up with was that the risk of death was related uniquely to the occurrence of organ failures. And this organ failure was not limited to the liver, measured here using bilirubin or coagulation, but any of these organ failures, whether it's liver, kidney, brain, coagulation, circulation, or respiration, were independent factors associated with risk of death. And in the gray here, dark gray, I've marked these numbers. A bilirubin of greater than 12 identifies an independently associated risk of death of patients with decompensated cirrhosis, creatinine of greater than 2 milligrams per DL, the presence of grade 3 to 4 encephalopathy and INR of 2.5, requirement of vasopressors to keep the blood pressure going, or low PaO to FiO2 ratio to diagnose individual organ failures. Liver, kidney, creatinine, brain, HE, grade 3 to 4, coagulation, circulation, respiration. Each of these independently produce a risk of death. But therefore, it's worthwhile looking at this column here. As you can see, we are looking at 28-day mortality. And you can see if 2 of these 6 organs are failing, the risk of death is nearly 32%. If 3 or more of the organs fail, then 68 to 90% risk of death. But even in ACLF1, which is defined by either single kidney failure or any other organ failure, they require mild kidney dysfunction or mild brain dysfunction to diagnose ACLF1. But of course, risk of death, as you can see, if you got ACLF1 is nearly 22, 23%. But if you've got no ACLF, the risk of death is very low, between 5, 4, and 6%. So very clear demarcation in the risk of death of patients who've got ACLF versus no ACLF, defining that this is something very unique about this population that transits from that developed organ failure. And this was the concept that was elaborated in the canonic study, which defines for the first time the importance of organ failures in the occurrence of mortality, short-term mortality of these patient populations. But of course, this slide is important, because it tells you that this is not a dead end. This is a syndrome still with a potential for reversibility. And this gives us the sense that we may be able to treat these patients with novel drugs and devices in the future. So what this shows you here is, this is telling you about the patients, how they are when they present to the hospital. And this tells you what's happened to them between day 5 and 7 of hospital presentation. And the green is that if you come in with ACLF grade 1, 55% of patients will resolve ACLF, but 12% will progress. And to the contrary here, if you got 3 organ failures, ACLF grade 3, only 16% will recover spontaneously and 68% will remain there. And the important point here is that if you resolve ACLF, then the risk of death is like that of patient with no ACLF. If, however, you had no ACLF grade 1 at presentation, and you progress, then the risk of death is like that of ACLF grade 3. So it is a very, very dynamic syndrome where a patient might come in with ACLF grade 3, they might remain in ACLF grade 3 and a very high risk of death. If somebody comes in ACLF grade 3, they recover, the chances of survival is like that of no ACLF patients. So remember, resolution of ACLF at day 5 to 7 defines the risk of future death. And I'll talk a little bit more about it in the next slides. So ACLF is potentially reversible, giving us opportunities to treat this patient better. So just to go back one step, what I've shown you here is what we call the Cliff Organ Failure Score. It's a score from 6 to 18. In this here, what I've shown you is 3 grades of ACLF. So there are 2 new nomenclature, Cliff Organ Failure Score and ACLF grades. And I'm going to introduce a 3rd score for you. It is called the Cliff C ACLF score, which is essentially what we did was to then go back and look at these patients in more detail. And what we wanted to do there was to come up with a scoring system that defined the individual patient's risk of death that you can calculate on a day-to-day basis. And what we came up with was age and white cell count, in addition to the Cliff Organ Failure Score, were independent predictors of risk of death. And we combined them into a new formula, which is a score from 0 to 100. And as you can see, this gives you a risk of death at 28 days. And you can see here that most of the patients are here in the center. And at the bottom end, the risk of death is very low. But here, as you can see, the risk of death is exponentially high. Our patient has a score of 57. And as you can see here, the risk of death is about 55% that you can read off this curve. It's not a straight line, it's a sigmoid curve. And here what we showed was that performed significantly better than any of the other scoring systems there are for acutely decompensated cirrhotic patients. So what I've shown you is data about what is the Cliff Organ Failure Score, 6 to 18. I told you the 3 grades of ACLF with different risk of death. And then I've shown you this score, a Cliff C ACLF score, score from 0 to 100, that can be updated sequentially and provides a risk of death in a patient on a day-to-day basis. You can check to see as to where the patient is. But this creates the model for how we can treat these patients better now in the future. Which patients should we select for transplantation? Which patients are likely to be futile in the ICU? And I'll come and talk more about it later on. Okay, so one of the things that you may have noticed from what I've told you with the CLIFSI ACLF score is that was the first time that we identified that the white cell count, which is a marker of systemic inflammation, was an independent predictor of risk of death. And that was the first clue we had to determine that this prognostic classification may be pathophysiologically distinct. And this is what I show here in this slide. What you see here is that the patients show whatever marker you choose to look at. If you've got compensated cirrhosis and CC, acutely decompensated patient, which is when David was admitted to the hospital and when he develops ACLF, there is a very marked stepwise increase in markers of systemic inflammation. Here looking at white cell count, this is CRP, TNF-alpha, IL-8, but whatever you choose to measure, whether it is pro-inflammatory cytokines or anti-inflammatory cytokines, they are elevated and increase in a stepwise way from as it moves from AD to ACLF. So the first clue was that from the pathophysiologic perspective, there was something unique about ACLF, which was the occurrence of organ failure. But this organ failure was associated with the occurrence of marked systemic inflammation. And whatever we have done since then, this slide is a summary of many papers out there, was trying to understand why this systemic inflammation occurs. And what this slide tries to show is the kind of pathophysiologic mechanisms that underlie the systemic inflammation that these people have. And what I'm showing you here is David in the community. He then has a binge, develops acute alcoholic hepatitis, but develops, has a lot of stuff going on inside him. He has more leaky gut. He's got accumulation of pathogen-associated molecular patterns. His liver cells start to die, but the death of these liver cells is from non-apoptotic mechanisms, which means that they're dying from immunogenic forms of cell death. He's got very severe albumin dysfunction. Not only is the albumin concentration low, but it's dysfunctional. He's got a hyperammonemia, which is contributing probably to the development of his encephalopathy. If you look at his inflammatory cells, or particularly his organs, if you look at his liver, kidney, and brain, there's marked upregulation of the toll-like receptor 4, which is, as you know, a ligand for the DAMPs and PAMPs. Increased IL-1 beta signaling pathways, inflammasome is activated, which collectively leads to systemic inflammation, which culminates in these two phenomena. So you've got systemic inflammation, and it produces organ pathology through very severe endothelial dysfunction and metabolic failure, which we now start to call mitochondrial failure, and many lines of investigation pointing in that same direction. So a complex pathophysiology. These are all upstream, I think, of systemic inflammation. These are downstream effector pathways that leads to organ immunopathology. So if you look at the organs, they show signs of immune activation and immunological cell death. And this is what is measured by these score systems here. And what this model can therefore be used to generate new therapies, which I'm going to talk about in the next part of my talk. So pathophysiologically distinct, it has many different underlying mechanisms, but the central phenomena that we can measure is systemic inflammation, and that leads to organ dysfunction. The subsequent part of my talk is really about why is it important for us to know about ACLF? And I'm going to talk about these different areas to bring you up to where we are. So it is obviously, as I've shown you, maybe important for risk stratification and generating management decisions. It is useful in defining the futility of ongoing care in patients that are not suitable for transplantation. Of course, it's important for referral for liver transplantation, and I'm going to talk a little bit about this. And then I'm going to end with showing you how the area is growing with the development of new therapies for this syndrome. The first point here is that if we want to improve the outcomes of ACLF patients, we have to do everything right and early. So what my mantra really now is go very early, go very hard, because if you resolve the ACLF, you will make your patient survive. So in order to do that, your intensive care unit has got to be very closely working with you as a hepatologist on the ground in order to get the best outcomes. So for instance, you need to be very clear about what do you do about variceal bleeding, which patient has early tips, how do you manage renal dysfunction early, how do you diagnose ACLF early so that you can get them into the ICU. And infection is a key element because, looking for the cause of infection, source control, and management appropriately of early use of broad spectrum antibiotics is crucial. Many hospitals, even in the UK, suffer from, a degree of nihilism where these patients are not allowed admission to the ICU. You should argue very strongly with that. As I've said to you, how do you manage complications like bleeding, infection, encephalopathy, ascites? Each one can lead to increased risk of death if you don't manage them. These patients are multiple support systems, so you need to monitor what's going on and institute appropriate treatment as it goes support. And if you want to get the chances that you're going to survive 10, 20, 30, 40% patients of ACLF3 or bridge them to transplantation, you need to go early organ support and early, but you're going to decide with your teams as to how you're going to go about managing them. And there is emerging consensus as to what you should do, but it's mainly taken from the intensive care world. So now, one of the biggest issues that we have in managing ACLF grade 3 patients with multiple organ failure is as to how do we define as to what to do with them, because with our current intensive care, we can keep them alive for a long, long, long time. And the question that we asked here was whether we can use the CLIF ACLF score to help us make some decisions about potential, and this is really important word, potential for futility. Futility is very difficult to define in clinical practice, but you need certain guidance in terms of saying that, look, we've done enough for this patient for a length of time. And so what we did here was to look at patients between 3 and 5 days of intensive ICU. So these patients came into the ICU, they were intensely supported for 3 to 5 days. And then if you can see that if their CLIF ACLF score remains greater than 70, then the risk of death is extremely high. Okay, so you can start to think about having discussions with a family but the caveat here is that this is in the absence of availability of liver transplantation that you can think about potential for futility of ongoing ICU care. And again, but of course, futility needs to be decided on a case-by-case basis. But it is very likely, as you can see, the confidence intervals are 82 to 100%. So if you talk about futility, there's nothing 100% in the world. So it's just something that you need to keep at the back of your mind, that these kind of scoring systems are not 100%. So talking about standard of care management futility, but what has changed completely in our clinical practice vis-a-vis patients with ACLF is demonstration that they might survive if you transplant even the sickest. But of course, transplantation of ACLF patients is not easy. And that's because of this whole idea of the balance between equity versus efficiency, which means that we're going to lose a lot of organs, at least some of the organs, because of transplanting very sick people. But of course, we've got to maximize utility. And what is the balance is what this story is about. So the first point I want to make is that patients that are allocated organs in Europe using the MELD sodium score underestimates the risk of death. This is what we found here on this particular study we did in the ICU. We did in a very large number of patients from the UNOS registry. What this here is in the y-axis is mortality rate on the waiting list. Here are patients with no ACLF, ACLF grade 1, 2, and 3. And here in the different shades of blue are patients with different MELD scores. What you can see here is that in patients with even with low MELD, as you can see, less than 25, the risk of death is very high if they've got ACLF grade 2 or 3. So what this tells you is that the MELD score is not able to identify patients at high risk of death on the waiting list for a transplant. And therefore, we think it's not fit for purpose. But of course, it's not surprising from what I've told you already, because MELD doesn't take into account circulation, respiration, or brain failure, each of which are independent predictors of mortality. Okay, so here, as you can see, risk of death, ACLF score is able to identify patients at risk of death, which is not identified by the MELD sodium score. And this is very important. But of course, the most important question is, how do they do if you do transplant them? And these are the data, again, from the UNOS database. Again, as you can see, large numbers of patients here transplanted between 2005 and 2016. What you can see here is these patients are transplanted with ACLF 0, 1, and 2. And here are patients with ACLF grade 3. And what you can see is that the risk of mortality at 12 months after transplantation is only about 15%, compared with ACLF grade 3 patients having nearly 70 to 80% risk of death if they're not transplanted. So very clear evidence of transplant benefit. Survival, 12-month survival over 80%, risk of death of 70 to 80%. It's a no-brainer that these patients can do well. But of course, the most important point that is that these are very highly selected patients that are being looked after for liver transplantation. But that is important. If you select your patients right, you can have great outcomes, even for those with ACLF grade 3. So therefore, what are the limits of transplantation for these patients? And as you can see here, severe comorbidities, for instance, the presence of ARDS, patients do badly. Patients requiring dual inotropes, for instance, for maintaining blood pressure, very high norepinephrine dosages, severe lactatemia, and uncontrolled infection. These are potential contraindications, but of course, none of these are absolute, and you need to, again, consider these on a case-by-case basis. What we also, so we did a large study in Europe, which is the EF-CLIF ELITA collaborative study, where we were looking to seeing as to whether these data that we generated in UNOS is what we find in Europe as well. And we confirmed the same data that we found in UNOS in Europe. But what we also found, which was really interesting, was that there was a serious lack of equity of access to transplantation. So for instance, if you were in Spain, in France, or if you're in Germany, or even in Italy, there's more likelihood of getting an organ compared with if you're in the UK, for instance, only 2.9% of these patients with decompensated cirrhosis with ACLF3 were transplanted, compared with Spain, very low, Poland, very low, Netherlands, very low. So there's serious lack of equity of access to liver transplantation for this patient population. And I am very happy to say that based upon all the work that we've done over the years, in the UK, there's a new category that has just been introduced for transplantation of patients with ACLF, where patients are now allocated organs just below the acute liver failure list. And these are the new tier criteria where we are, these people will have access to organs just after the patients that get organs for acute liver failure. As you can see here, the inclusion criteria are, we're not doing alcoholic hepatitics in the UK, but ACLF with greater than 28-day, so less than 50% with ACLF grade 3 or higher. We don't transplant patients in this list if they got ACLF grade 3, age of greater than 60, they've got active infection, they've got very severe multi-organ failure with high likelihood of futility, excessive comorbidity, and serious frailty. And what we have is a system where we've got to list them on the special criteria where they're reviewed by an independent panel. So this program was introduced in the UK about a year ago, and these are data till for the first year or so. And as you can see, there were 22 registrations. As you can see here, these are very, very sick people, mainly young people. And on this list, they waited for a median of 2 days, 2.5 days. 18 patients received an organ. And as you can see here, most of these patients were alive. 16 of the 18 patients survived. So they're very good clinical outcomes with introduction of this new tier. 3 patients were removed because of they waited for 8 days or more, and they all died, and 1 patient on the waiting list. So really speaking, very, very, very clear indication that these patients can do well with liver transplantation. But in order to, of course, what I've told you is shown you some data, but these patients can have the many, many unanswered questions about what may happen to these people. And therefore, there's a large clinical trial, large clinical study, which is being organized by the European Foundation for the Study of Chronic Liver Failure in collaboration with ELITA and ILTS. We're going to study over 2,000 patients who are being transplanted with ACLF grade 2 or 3, patients with no ACLF, but MELD of greater than 20 as a control group, and group 3 is a group of patients who are not listed, and we're going to just follow them to see what happened. We'll follow them for a year, following the transplantation, to decide whether or not they have reasonable outcomes. And we're going to define new criteria to select patients, futility criteria, etc. So watch this space. We've now got nearly 600 patients in this trial, and hopefully we'll have some first data at the end of this year. So that's about transplantation. But in the next slides, what I just want to show you is how the field is moving forward in terms of finding new therapies for this syndrome. And I take you back to this slide, which shows you the pathophysiologic basis for how this works. So, on this model, you can build how we can treat these people better in the future. So you can target cell death using new agents that target different modes of cell death. Targeting apoptosis, americasan was not shown to work, but there are novel mechanisms of targeting these non-immunogenic forms of cell death, and they're very specific inhibitors that will be trialed hopefully very soon. There is, of course, trials of albumin ongoing in earlier phases of liver failure. Ornithine phenylactate is a drug that's in a phase 3 clinical trial for targeting ammonia and reducing encephalopathy. There is a large trial of a combination of GCSF and a TLR4 antagonist called GTAC which has been funded by the EU, which is due to start very soon. GCSF, unfortunately, has not been shown to work very well in a recently completed clinical trial. YW2023 is a pro-regenerative molecule, and hopefully we'll see some results of that very soon. As you may know, there's a large clinical trial of plasma exchange running as we speak, called Apache study. Dialive is a new liver dialysis machine that we're building that just finished its phase 2 study. It's ready for pivotal studies. Liver transplantation, of course, is a real potential option. And of course, TLR4 antagonist that I've shown to you is also in a clinical trial as a third arm of the GTAC study. So there are many clinical trials that are opening up in this area, which hopefully will define novel approaches to treatment of this syndrome, which is associated with very high risk of death. So I just want to summarize by saying that ACLF is indeed clinically, prognostically, and pathophysiologically distinct. And it's from the clinical and the pathophysiologic perspective, it has redefined cirrhosis by putting in two important components: the importance of organ failure and the importance of systemic inflammation, which we think is really the underlying mechanism. And the pathways that lead to inflammation and the causes of inflammation may well be the novel therapeutic targets. I think it is clear that ACLF classification, as we see it now, allows patient stratification, determination of futility, prioritization for liver transplantation, and enrollment into many clinical trials that hopefully will reduce the deaths of these patients in the future. And I just want to end with that, just to say thank you to a lot of my fellows who over the years have worked with me on this program that I've shown you today on ACLF and various pathophysiologic mechanisms, and the many, many different organizations that fund the work that we do. So I'll end with that and say thank you very much for this very kind invitation and the opportunity to share my thoughts with you.